Thank you, Monica, for that kind introduction. It's my pleasure, and I'm humbled to introduce Dr. Sankaran. Good to meet you, Dr. Sankaran, again, this time virtually. Hope to see you in Abu Dhabi again sometime soon. So she's somebody who needs no introduction, really, but it's customary, I have to introduce her. So Professor Sankaran has a long-standing academic background. She started her career at the Wayne University School of Medicine in 1975. She went on to lead the neonatal perinatal medicine program at the Detroit Medical Center for almost 3 decades. And as we all know, she has pioneered a lot of work in long-term longitudinal studies and contributed multiple RCTs, mainly in the field of neonatal neurology. And her groundbreaking work on whole body hypothermia is what kind of set the standard for the treatment around the world when it was first published in 2005 and just confirmed by other studies and other meta-analysis. So that became a standard of care. Not one to rest on her laurels, Dr. Sankaran went on to do further studies to see if deeper cooling and cooling more preterm babies is going to be beneficial in the background of hypoxic ischemic encephalopathy, and found out it was not a great idea. And those studies were stopped, but we are waiting for the long-term outcomes from those studies. She's continuing to be active in that field. Just to kind of understand the impact of her work on the neonatal outcomes, a photograph of her and one of the first babies who participated in the trial hangs in the hallway of the director of the National Institute of Child Health and Human Development Neonatal Research Network as one of the most significant NICHD network contribution in the last 25 years. So without much ado, over to Dr. Sankaran.
Thank you. So let me share screen and okay. So I'm going to talk about neuroprotection. Oops, sorry, that's not the first slide. I'm going to talk about hypoxic ischemic encephalopathy and neuroprotection. So currently the evidence is there for hypothermia therapy for infants with moderate and severe encephalopathy in the high-income countries. I'm going to cover clinical monitoring during hypothermia. I will discuss briefly therapeutic drift in hypothermia therapy, including use in premature infants and use in infants with mild HIE. I will touch on hypothermia in the low and middle income countries and then end with just future directions. So the current evidence for hypothermia therapy for infants with moderate and severe HIE is implementing it at 33.5 degrees Celsius for 72 hours. And of course, this is based on data from the randomized controlled trials in the high-income countries. And to just to give you the overview, the rate of death or disability at 18 to 24 months of age, as you can see in this slide, is reduced between the from the control group to the hypothermia group. In the statistically significant decrease was seen in the NICHD trial from 62 to 44%, from the European trial from 83 to 51%, the trial in China, and the ICE trial from 66 to 51%. If we look at the other outcome, which is cerebral palsy at 18 to 24 months of age, you see that there was a significant decrease between control and hypothermia in the TOBI trial from 41 to 28, the European from 48 to 12, and the trial from China from 28 to 14. The current data on the rate of death or disability actually has been reduced still further with cooling, and currently in the trial that we did evaluating longer and deeper cooling on outcome, we had a rate of death or disability of 29% in the overall group. In the moderate hypothermia infants, it was reduced to 20%. In the severe hypothermia infants, it was reduced from our first trial in the cool group from 72 to 62%. And the mortality rate was reduced from 24% to the current 9%. The number of infants with a mental developmental index or a Bayley-III cognitive score in the normal range has increased from currently to 65%. The psychomotor developmental index or the Bayley-III motor has increased to 68%. Interestingly enough, we did not find a decrease in the rate of cerebral palsy. Now, does neuroprotection with hypothermia persist to childhood? This has also been evaluated very carefully in the CoolCap trial using a maternal interview of 62 of 135 surviving children. It was noted that at 6 to 7 years of age, the disability status at 18 months was strongly correlated with the ratings on the parent interview. There was no significant effective treatment. In the NICHD trial, we evaluated an outcome of death or IQ less than 70. And what we found was that there was a reduction in this outcome from 62 to 47% at 6 to 7 years of age, which was significant in the unadjusted risk ratio. But once we added center, we lost that significance. The secondary outcomes at 6 to 7 years of age showed that there was the reduction in the infants in the hypothermia group, both in mortality or cerebral palsy, and also in death or severe disability. Now, when we switched to the TOBY trial, where the outcome was number of surviving children at 6 to 7 years of age with an IQ greater than 85 from the original trial, you can see that the number of infants in the hypothermia group was 52%, significantly higher than the infants in the control group. The secondary outcomes of the TOBY trial did not show a significant difference in death or in cerebral palsy. So I think this has clearly shown that hypothermia in the high-income countries was effective. So when hypothermia is implemented, what is the monitoring that should occur? Probably the most important thing is the selection of the infants for hypothermia. They should be equal to or greater than 36 weeks of age, less than 6 hours of age, which is considered the time of neuroprotection. And infants should be selected who are at highest risk. So that is those with severe birth acidosis or in the absence of cord blood gases or gases within 1 hour of age, the need for birth resuscitation that is continued for at least 10 minutes. And infants should have moderate or severe encephalopathy. The challenges of a neurologic exam being done so early within 6 hours of age is that we have to remember there will be an impact of maternal anesthesia and analgesia. It depends on the severity of the injury and the timing of the injury in the perinatal period to the fetus, the ability of the neonate to recover, any associated conditions, and how good the resuscitation was. So these factors have to be kept into consideration. Here you see the modified SANAT exam where 6 parameters are evaluated: level of consciousness, spontaneous activity, posture, tone, primitive reflexes, and autonomic nervous system. And to be eligible for cooling, the infant should have at least 3 of these parameters in the moderate category or in the severe category. It is important to be very consistent with the neurologic exam, to have clear definitions for the categories of the exam, to certify new examiners and retrain examiners on an annual basis. So now the neonatal exam utilized for the NICHD trials are available for public use, and this is the website. So hypothermia in the trials is to be administered only for infants meeting moderate or severe encephalopathy criteria. What are the other parameters during monitoring? The studies that I've looked at data in the randomized trials, especially the NICHD and the TOBI trial, found that the age of initiation at cooling within the first 6 hours really did not impact on outcome at 18 months. So as long as you cool within that first 6 hours after a good neurologic exam. The location of birth was also not found to be different as far as the outcome. So inborn infants and outborn infants had similar outcomes in the NICHD trial. Again, secondary studies from the NICHD trial showed that 25% of infants with a 10-minute APGAR score of 0 survived without disability at school age. And probably very important is that both the NICHD trial and the COOL-CAT trial noted that elevated temperatures before, in the control group in the trials was associated with adverse outcomes. So therefore, we need to be careful that elevated temperatures before and after hypothermia should be avoided because of abnormalities noted both with MR spectroscopy and also indirect measurements of brain temperature that now shows that injured brains have elevated temperatures even with cooling. The other factors to remember during monitoring is that smaller and sicker infants may require blood pressure support both during induction and during maintenance. 2 of the trials noted that low PCO2s are related to a higher risk of disability, so we should maintain PCO2 in the normal range. Hyperoxia was associated with more injury in the secondary analysis of the COOL-CAT trial, and also both elevations in blood sugar as well, both increased and decreased blood sugar was associated with adverse outcome. So these factors have to be all considered when hypothermia is being administered. Continuous video EEG or an amplitude integrated EEG is probably better than intermittent EEG alone and has been shown to decrease anti-seizure medication use. Another important factor is seizures during rewarming, which by itself is associated with adverse outcome. This was the secondary analysis of the Optimizing Cooling Strategies trial that was recently published. And what was important was that 23% of the infants had actually new onset seizures during the rewarming phase. And the last caution is that both sedation and analgesia should be used with caution, and keep in mind that there can be accumulation of morphine during the cooling process. Now, when we look at other factors, the CSF biomarkers and the heart rate variability are very important tools that are being researched currently. The most predictable indicator of outcome, I think, is MR imaging, and this has been covered already and will be covered in more talks. It's a reliable predictor of outcome as seen in the NICHD trial, the TOBI trial, and the ICE trial. Other factors that we noted was that infants with HIE and cerebral palsy are at high risk for growth failure and for developmental delay. So we should focus on nutrition of these infants right from the time they go home. With a number of questionnaires that were administered to parents of children in the secondary studies that we have done, families of children with disabilities have higher financial, social, and personal needs. And there is a greater need for special education and early intervention services in the infants who are found early on to have cerebral palsy or developmental delay with encephalopathy. Spectroscopy is now coming out as a very good predictor of outcome. Here you see data on the NAA absolute concentration, which is in the first panel to your left, is lower among infants with adverse outcome following moderate or severe encephalopathy. The LAA to NA ratio showing a difference in the normal and adverse infants with an elevated ratio. The NAA to choline ratio and the NAA to creatine ratio also shows a difference between those infants who have normal outcomes and adverse outcomes. So this is going to be an early predictor of outcome in the neonatal period. And there was also a correlation between the absolute NAA and the Bailey scores, both the cognitive score in the first panel to your left, the motor score to your right, and the language score again. You can see that the infants with adverse outcomes who are shown in red had much lower concentrations than those who had a good outcome. So this is a very promising predictor of outcome. When you look at the prognostic accuracy of the biomarkers, looking at clinical assessment, cerebral function, MRI, diffusion MRI, and spectroscopy, the highest prediction association with outcome was seen in the absolute NAA concentrations. So the summary that I can tell you is that currently 18-month mortality with hypothermia is 9%. Death or moderate or severe CP is 29%. Disability is 29%. CP remains at 20%. 18-month outcome correlates with 6 or 7-year outcome. And it is really important to follow all infants with HIE at least for 18 months. In childhood, normal IQ is seen in 52% of the children. Cerebral palsy is 19%. And among those who are not disabled, among those without CP, 9% had an IQ of less than 70, and 31% were 70 to 84. Children with CP have multiple hospitalizations, early growth failure. The majority have an IQ less than 70, but 23% have a normal gait. Families with children with disabilities have financial, family, social, and personal challenges. In childhood, 32% of the children require special education services. 7% have behavior problems. And the early neonatal biomarkers of outcome is MR imaging and spectroscopy. Now I want to move on to therapeutic drift in hypothermia. There are publications that hypothermia has been used for postnatal collapse, severe surgical conditions, infants with mild HIE, and in preterm infants. I just want to focus on mild HIE and preterm infants. Looking at hypothermia for mild HIE, the recent surveys have shown that the majority of centers, both in the UK and more recently, as you can see in Vaughan and Toby in the French registry, a number of these registries and surveys have shown that physicians are currently cooling infants with mild HIE. However, no outcome data has been presented from these reports or from the majority of these reports. Infants with mild HIE have been inadvertently included in the original randomized controlled trials, and there have been 2 meta-analyses presented, both of which have not shown any benefit of cooling in the mild HIE infants that were included in the trials. The first publication had 91 infants, the second one had 117 infants, but you can see adverse outcome was no different in both groups. So are we ready for a randomized controlled trial of hypothermia? For mild HIE, I think it should be done. It should be designed to include infants at highest risk. That means only infants with acidosis or needing birth resuscitation. These infants should be carefully selected based on careful neurologic examination. The current depth and duration of cooling should be used because that's all we know currently, which is 33.5 Celsius for 72 hours. And the primary outcome should be long-term. So it should be cognitive and behavioral outcomes with the robust measures at 5 years of age. If a trial shows that cooling is safe and effective, then it should be offered. But if it is not safe and effective, this treatment can be discontinued. Now, as far as I know, there are no large-scale trials that are ongoing, although many are planned. Moving to the second area of therapeutic drift, this is hypothermia for preterm infants. And the basis for this, I think, is that the AAP guidelines originally included 35-week gestational age infants. But you can see from the TOBY registry, from the Vaughan registry, preterm infants were included, and 2 of the randomized controlled trials of hypothermia for HIE, the original trials, did include a few preterm infants. But we don't have any data that's published on these infants. I do think this evidence-based data will be available because there is an ongoing trial of hypothermia for preterm infants. The principal investigator is Rajeshs. We are looking at safety outcomes because remember, these are preterms. So hemorrhage, thrombosis, bleeding, acidosis, arrhythmia, NEC, etc. And the primary outcome is death or moderate or severe disability at 22 months corrected age. The sample size is 160 infants with the Bayesian analysis. Infants have all been enrolled. The follow-up is almost complete. The COVID epidemic has delayed some follow-up visits, but this data should be available soon. I also want to talk about hypothermia for encephalopathy in low and middle income countries. This is the HELIX trial that was presented by Dr. Thayal at the PAS last year and is published in Lancet. This trial was designed to look at HIE in low and middle income countries. So the inclusion criteria included infants who required resuscitation at 5 minutes or who had a 5-minute APGAR score less than 6 and had moderate or severe HIE. Infants with absent heart rate, life-threatening malformations, and those unable to attend follow-up visits were excluded. The sample size was 204 infants per arm to be able to detect a 30% risk difference. So here you have the results of the trial. The neonatal characteristics between the 202 hypothermia infants and the 206 usual care infants, there were no differences. You'll notice that the birth weight of the infants is a little on the low side. This trial was conducted in centers in India, Bangladesh. Now, the short-term outcomes, as can be seen on this slide, did show some disturbing data. There was gastric bleeding, persistent hypotension was increased in the hypothermia group, pulmonary hemorrhage, prolonged blood coagulation also increased in the hypothermia group. So also severe thrombocytopenia, and the mortality rate was increased prior to hospital discharge. When the 18-month outcome was evaluated, death or moderate or severe disability was 50% in the hypothermia and 47% in the control groups, and not different. Mortality up to 18 months was higher in the hypothermia group than in the control group. And then you can see the other secondary outcomes that were evaluated. The rate of microcephaly was actually a little bit higher in this trial than seen in the high-income studies. Spectroscopy was done on a subgroup of infants in the HELIX trial. There was no difference in absolute NAA concentrations and in the lactate to NAA ratio. So the conclusions of the HELIX trial was that cooling therapy, as performed in these hospitals that provided intensive care, did not reduce death or disability on the neurologic exam, nor did it reduce the imaging abnormalities. On the other hand, mortality was increased. The reason for this, has been discussed quite a bit. It's probably because the populations are different in the LMIC trial as opposed to the HIC trials, and that brain injury possibly occurred in the perinatal period due to, partial prolonged hypoxia or acute on chronic hypoxia. And the authors suggested that LMIC research should focus on primary prevention by focusing on improving antenatal and intrapartum care, especially in those areas that have very high disease burden. So what are the future directions for hypothermia for HIE? There are a number of studies that are currently ongoing on hypothermia plus therapies. These include EPO, melatonin, umbilical cord, milking. And of these, I think there's a tremendous amount of anticipation for the HEAL trial, which is hypothermia plus erythropoietin, that is completed and will be presented at the Pediatric Academic Society meetings this year in April. So we are looking at this trial with a great deal of interest. We know from prior published trials that xenon, magnesium sulfate, and topiramate were not found to be beneficial. And the future studies should be adequately powered, as hypothermia for HIE now has, at least in the high-income countries, a decreased mortality. And the gold standard for studies will still be 18 to 24 months. I would like to stop there and see if we have any questions.
Thank you, Dr. Sankaran, for the excellent overview of hypothermia and HIE. We do have a few questions from the audience. I think other people are still typing in. So one question you've already answered, what your view on the HELIX trial is. One of the criticisms of that is that the kind of landscape of healthcare in these countries is quite different. For example, what's available in the cities is quite different from what's available in the rural areas.
Exactly.
So is it ethical to kind of say we shouldn't do it where the facilities exist in such countries, where the standards might be on par with anywhere in the Western world? For example, what's happening in Delhi might not be the same happening in the periphery of Uttar Pradesh in India, for example. What's your view on that?
Well, I think, that it's a little bit difficult to say. If you do have intensive care and inborn infants, and you diagnose encephalopathy within the first 6 hours, I think with adequate consent discussion with the parents, because we still don't have any outcome data of the infants who are currently cooled in LMIC. And that is one of the concerns that I have. So for the centers that currently are cooling, I think it would be good for them to start looking at their follow-up data, looking at the safety and the efficacy data. In general, I would say that just because, the trial, first of all, was the largest one that was ever done, was done very meticulously. There was an external data safety monitoring board that evaluated the trial at periodic intervals and evaluated for both, safety and efficacy. And the trial was completely independent. In fact, was led by one of the PIs of the NICHD trials, the DSMB chair. So because of that, I think, I am concerned with the results of the trial. And I think the fact that we had so many babies who ended up with microcephaly. The other factor that I should have stressed was that almost 75% of the infants in this trial had seizures within 6 hours of age, which is much higher than that seen in the high-income country trials. And the acute perinatal sentinel events was much lower. So it looks as if this could be a sort of an injury that occurred earlier in the perinatal period than what we've seen with our HIC trials. So the question comes up, should we really focus a lot on what we can currently do, which is try and improve antenatal care and make sure we avoid, elevated temperatures for these children. I need to mention there is a very large trial that has started in India. It's called the PREVENT trial, which is looking at a very large number of women and infants. And the trial in the first year looks at the baseline data of the mothers and infants. And in the second year of the trial, randomizes women to care bundles, antenatal care bundles, and then looks at the outcomes. So I think that's a good, some data that we are really anxiously waiting for.
Thank you. We have a couple more questions from the audience. One is, I think we all know the answer to this, but for cord gases, which ones do you consider significant, venous or arterial, or either?
Well, either. I'm not, because we really could not get separate, venous and arterial. So we said, whatever is available is fine.
Yeah, that's great. One of the other questions which has come up in seizures associated with HIE, what anticonvulsions are currently recommended? I think it might be coming up in later talks. Do you go for Keppra or phenobarbital, age-old medicine?
It's really up to the clinicians, and I'm sure that Dr. Shalhouse is going to cover it in detail. From my experience within the neonatal network, we tended to use phenobarbital first as the first line, and then use Keppra after that if the seizures were unresponsive.
Okay. One of the other questions is about this is from me actually, the recommendations for neuroimaging. We started doing MRIs a couple of decades ago now. And initially they said a week to 10 days. Now we are doing it earlier and earlier with the advent of diffusion-weighted imaging and spectroscopy. So what's the current recommendations? How early and how late can you neuroimage to kind of prognosticate in these infants?
Well, I mean, I know that the, our first trial, which was of course 98 is when we started, the imaging was done much later. at 2 weeks of age. So now it is done much earlier, usually between day 5 and day 7. You know, I think too early is not. I think you need to wait to see what the injury is. And so between day 5 and day 7. Now the other speakers may have their own opinions on this. The longer, deeper trial was mentioned, and we do have MRIs on the majority of infants in the trial. And currently we are evaluating those MRIs, and we will be looking at the MRIs of infants in that trial.
Dr. DeVries probably will cover in her talk.
Yes, yes, I'm sure she will.
Yeah, one of the other questions which has come through, which again, from the trial data we know, so do we need to wait for neurological symptoms and if we resuscitate newborns, if they meet the cord pH criteria? But we probably know the answer to that. But one of the audience
But again, you know, my own opinion is that you have to wait for the infant to recover from the resuscitation. So you'll notice that in the HEAL trial, the inclusion criteria is after the first hour of age. So you had to wait for the first hour to see the response to resuscitation, and then you know, look and see if the child qualifies for HIE. I am concerned when delivery room temperatures are dropped and cooling is started right in the delivery room. I think that is way too early. So I would suggest, you know, looking at how the child responds to resuscitation, doing an exam and probably repeating it again, and then seeing if the child has moderate or severe HIE.
So that was going to be a follow-on question, this practice of passive cooling, which probably a lot of resuscitation guidelines do mention. So your recommendation would be to avoid that till we have adequate.
Yes, I would, you know, avoid hypothermia, but I would keep the child's temperature normal, in the normal range, while the child is being resuscitated, because you do have to respond to resuscitation.
We have a question from Dr. Rajesh.
Hi, Dr. Seetha. I'm one of the neonatal consultants, colleague of Hafiz. My question is based on what you've just said. We see a lot of babies being cooled based on the neurological examination in the delivery room or during the resuscitation, that he was slightly hypotonic, or there were some signs of not encephalopathy, but like low tone. And this we commonly see, and a lot of our babies are getting cooled based on that. Now, I think your answer, which I'm able to understand from your last answer, is that probably we should wait for an hour at least to review the neurological examination.
Yes, I think you should resuscitate the infant. You know, there are infants with anemia, severe anemia, who are very floppy at birth, and you need to stabilize them, you know, give them a blood transfusion and look at the response to that, and then do the neurologic exam. I do have concerns about initiating cooling in the delivery room. I think I don't think those are babies with moderate or severe HIE. I'm concerned that you're cooling infants who could very well be mild HIE.
True.
One significant question. Sorry.
No, so I think that is one of the reasons why in the HEAL trial they were very specific. You had to wait for an hour, and so I'm a little bit curious how the current trial, that is, or the trial that's about to be started on umbilical cord milking. I'm just curious to see how that trial is going to proceed.
There's one question from the audience linking the previous talk to this one. So if, for example, a term baby was encephalopathic and you find intracerebral hemorrhage on your early ultrasound scans, would you continue cooling or not? If you meet the criteria.
That is a very good question. It's a little bit hard to answer because we don't have that many MRIs during the period of cooling, during the 72-hour period. Now, if you have an infant who is severely encephalopathic and continues to be encephalopathic during the period of cooling, and you decide to redirect care, I think that's a different issue. You know, you want to redirect care, you might get an MRI to see what the brain looks like, and the MRI shows hemispheric devastation. That I agree, you know, with ischemia and hemorrhage, that I agree that may help you to make your decision how to, whether to continue cooling or whether to withdraw support. Most of the data on the MRI findings has actually come after the period of cooling.
Okay. There's another question from a low-income country background. This is the use of alternative methods of cooling. I think there have been a few trials on that, like the use of ice bags and water-cooled bags as an alternative method of hypothermia. What's your opinion on that?
Well, I am concerned about that, because I think it is really important to have very steady temperature during the period of cooling. So I am concerned when you say, you know, we use ice bags, or so I would suggest using, you know, if you were to use cooling, it would have to be a very a method of cooling that would provide sustained temperatures. Because these infants are, especially the smaller, sicker infants, have very frequent drops of temperature and very labile temperatures.
I think one of the questions is about mild HIE and brain insults. So I think you've already addressed that we need more evidence on that. So
yes, that is my opinion, that we do need to see whether you know, cooling is safe and effective in mild cases. Yes.
Thank you, Dr. Sankaran, for this excellent overview on the topic. If there are no more questions, I think there might be other questions coming up. So if you can stay with us and can answer some in the chat box, that'd be great.